Good afternoon, ladies and gentlemen, and a warm and friendly welcome from the beautiful city of Cape Town, voted the most best city in the world 2025. So it gives us great pleasure this afternoon to have Dr. Hisham Arab, who's our presenter, and he's presenting on a global update on the use of progesterone in miscarriages. He hails, in fact, from Jeddah in Saudi Arabia. It's a wonderful part of the world as well, Saudi in the news. And also, he is a highly accomplished obstetrician gynecologist with extensive experience in maternal fetal medicine, assisted reproduction, and minimal invasive gynecology. He has contributed significantly to the field through his research, teaching activities, and involvement in various societies and organizations worldwide. He, in fact, is known as Mr. Progesterone in the Middle East, and it gives us great pleasure to welcome him on behalf of Abbott. And we also have Devon, Samir, Kreesum, and Hendrik from Abbott with us this afternoon on this platform. We're going to start, in fact, by having a quick video, and then we're going to go on with Dr. Hisham Arab's presentation. My name is Peter de Jong, and on behalf of the Pelvic Floor Foundation of South Africa, and it is a great honor to have you over here. We have hundreds and hundreds of delegates logged on to explain the great popularity of Hisham Arab and why it's important to all be with us on this platform for this World Expo. Nadia, would you roll the video, please?
Progesterone is a steroid comprising of 3 cyclohexane rings and 1 cyclopentane ring. It is manufactured for therapeutic use from the wild yam root Dioscorea species. Due to rapid first-pass liver metabolism, progesterone has variable concentrations and very low oral bioavailability. Therefore, it is administered via injection or vaginal route, which are not easy to use and associated with side effects. Dydrogesterone was introduced for clinical use under the trade name Dufeston in the 1960s for treatment of conditions associated with progesterone deficiency. The manufacturing process of dydrogesterone is highly complex. It starts with the chemical modification of progesterone, followed by a critical phase of transformation into dydrogesterone. This is done by passing it through UV light at an appropriate wavelength, intensity and time sequence, resulting in a unique, modified retrosteroid structure. This manufacturing process makes dydrogesterone the only commercially available retroprogesterone. The bent conformation of oral dydrogesterone enhances the rigidity of the molecule compared to progesterone. Due to its unique structure, dydrogesterone is highly selective for progesterone receptors, supplementing deficiency of endogenous progesterone. It has negligible interaction with other steroid receptors, resulting in a lack of androgenic, estrogenic, glucocorticoid and mineralocorticoid effects that can occur with other progestogens. Dufeston, containing 10 mg dydrogesterone in each tablet, is formulated to have good bioavailability, enabling convenient, patient-friendly oral administration. Improved oral bioavailability and the receptor agonist activity of its metabolites causes secretory transformation of the endometrium, progestational activity, at a dose 10 to 20 times lower than micronized progesterone. Various progestogens have been investigated to support endogenous progesterone in the treatment of luteal phase deficiency. Only Dufeston, progesterone, and 17-alpha hydroxyprogesterone caproate are currently approved for clinical use during pregnancy. In women undergoing assisted reproduction, Dufaston supplements endogenous progesterone and provides orally effective luteal phase support, contributing to successful and comparable pregnancy outcomes versus vaginal micronized progesterone. To date, around 113 million women throughout the world have experience with Dufaston, including 20 million fetuses exposed to dydrogesterone in utero.
Right, Hisham, Dr. Hisham Arab, and he's going to be speaking on global update on the use of progesterone in miscarriages. A great warm welcome from Cape Town. I'm sorry that the video isn't running completely and properly, but could you share your slides, please, Hisham? Thank you.
You can see me well?
Yep, we got you on full screen.
Thank you very much. First of all, Dr. DeYoung for the kind introduction. I'd like to thank Abbott for their invitation. And I'm really very much happy here to join my colleagues in South Africa, which I have enjoyed some time with them during the past few months. However, I'll be going along with this topic that really reviewing the global publications as well as guidelines in terms of the management of miscarriages. And here, let me just start with the first one, which is really what are the risk factors of pregnancy. And if you look at them, you find, for example, pre-existing diseases or pregnancy complications, obesity and lifestyle, advanced maternal age, but one of them also is a miscarriage. So in itself is a risk factor that may increase the risk of complications in pregnancy. When we look at the concept of miscarriage, I mean, out of all type of miscarriages, whether it is a missed, inevitable, incomplete, complete, or septic, there are only two miscarriages that can be prevented. And these are the threatened and the recurrent miscarriages. Now, preventable miscarriages, you can say that out of all pregnancies, 25% of them suffer from threatened miscarriage, and unfortunately, half of them will miscarry. And out of all pregnancies, 4% of them will suffer from recurrent miscarriages, and unfortunately, 1/3 of them is miscarrying. And here is the concept, how can we prevent these losses? Now, the reason we're talking about miscarriages is because of the consequences of having lost a pregnancy in the early part of it. I mean,
what could you see or what could you hear? Or how did it look? Pretty bad.
Sorry, can you mute your mic, please, Nadir?
So there are some psychological consequences of having just one miscarriage that may goes on for a long time, even for 4 months. For example, anxiety in 30 to 50%, depression in 10 to 15%. Also, 43% of female partners, not the female herself, experience some form of.
All right, I just wanted to know what was happening, so I can explain to
sorry, excuse me, Nadir, we can hear you speaking. Can you mute your microphone, please? Okay, Hisham, please continue.
Sure. And then, of course, the post-traumatic stress syndrome that has been really also been reported in those women who had suffered a loss in their early part of pregnancy. Now, not just the psychological part. Look at this systematic review where they looked at more than actually about 14 studies, yes. And for those patients who had just threatened miscarriage, that means bleeding in the first trimester. So that, in essence, has really created a very high-risk pregnancy that may really suffer from antepartum hemorrhage with an odd ratio of 2.5, premature delivery with an odds ratio of 2, so doubling the risk of premature labor and IUGR, as well as low birth weight. And look at the perinatal mortality is doubled just for the sake of having a bleeding in the first trimester. Isn't this an important and significant complication in her pregnancy? Let me share with you some South African data. Now, according to their publication just about 2023, it says that for those who are aware of their pregnancy, the rate of miscarriages falls between 10 to 25%, according to what I found in your literature, ladies and gentlemen. And the rate of first pregnancy miscarriages during the first trimester is around 19%. This is a very beautiful publication, came out in 2021, looking at the pregnancy loss and postpartum mortality in sub-Saharan African setting. And here you can see that out of 25,000 pregnancies that were examined, 941 were actually had a history of miscarriage or loss of pregnancy, whether it is an abortion, a stillbirth, or even miscarriage in about 20% of them. What did they found? The mortality rate was 3 times higher in women who experienced the pregnancy loss. You see the RR is 3.23. So it shows you here it's not something that's easy or something that you can underestimate or you can see it is not significant. It's highly significant at all levels. Now, so how to quench the threat of a miscarriage? So if you have a patient calling you with bleeding in the first trimester, and you can tell her that still you can give her as a brilliant advice to save that pregnancy. Now, I just want to caution you here with different approaches, but this is my approach, all right? There are 5 questions I ask myself in case of threatened miscarriage when I get that phone call from my patient to say she's bleeding and she's about 8 or 9 weeks pregnant. First question come to my mind is the patient's condition stable? Of course, she's bleeding. So here is important to assess the amount of bleeding. And this is actually will help me to tell the patient when to go to hospital. So the simplest thing, the patient cannot weigh the blood itself or measure the amount of bleeding, but you just simply tell her, is that bleeding similar to the amount of a period that you're having every month? If it is, then this is significant and she should go to hospital. If it's less than that, of course, you can tell her, you can be reassured and I see you tomorrow in my office. However, once you have really said that this is a patient has really maybe it's a significant bleeding, then the next thing will be to assess her vital signs, because we have seen that even with cases of just threatened miscarriage, still a viable fetus, but she is bleeding, she can bleed so heavily and that can be affecting her vital signs. She might go into shock. And here it's important you do the CBC, which is important to check her hemoglobin, but more importantly is her RH status, because according to the American College of Studying Gynecology, they reported about 1.5% of cases of RH incompatibility were due to the unawareness of the RH status of the patients coming at threatened miscarriage. Now, the second question, is the pregnancy viable? Okay, well, I have seen her emergency room, for example. So the first thing I want to assess, is this really a significant a pregnancy that is still viable? I can mention to you now the signs of non-viability, because if any of these signs is there, that means that this fetus this pregnancy is not viable, and then you just ignore it because it's just too late or there is nothing to do about it. It's already non-viable. However, so when you look at this publication, came out in 2013, New England Journal of Medicine, they highlighted the exact 4 or 5 criteria of non-viability. For example, a crown rump length of more than or equal to 7 millimeter and no heartbeat, or a mean gestation diameter of more than 25 millimeter and no embryo. and so on. So if that is represent, it is non-viable. If it's not, then you can see the fetus, fetal pole, you can see pulsation, but also you can see on ultrasound the subchorionic hematoma. And this is significant, in fact, because the presence of subchorionic hemorrhage has increased the loss rate in those cases with threatened miscarriage. Now, question number 3, which is, what's the likelihood of the pregnancy to continue? So now I have established that the case may be stable and this is a viable pregnancy I have to deal with, but I have also to tell the patient what is this likelihood of continuing her pregnancy with this kind of bleeding she's having. Well, there are 2 methods. Number 1 is the beta-HCG titer, which we all know about. You do it twice, 48 hours apart, and it should be doubling. Simple as that, but that's fine. But we have also some other marker that is really coming in the market these days, which is measuring the serum progesterone level in those cases. Okay, we're not measuring the serum estradiol or PAP-A or inhibin or whatever, because it's only progesterone that really comes out with the early part of pregnancy, even before pregnancy takes place from the corpus luteum, and start to go up and increasing in a specific manner. And here I have seen that a cutoff of more than 35 nanomoles per liter, that means there is a likelihood of this pregnancy to continue. This is not on the top of my head. These are the studies that has been coming out again and again. The last one of them was Tan in 2020, where he actually established this kind of cutoff, and he said, well, below that, more likely this pregnancy will end up, and above this, more likely will continue. And this is why they have even went further to look about the sensitivity and the specificity of this test using the progesterone just for once. You don't do it again, just one marker, in order to tell the patient, well, if you find the level of, for example, 10 nanogram per ml, there is more likely this pregnancy will end, which is about 25 nanomoles per liter. So this is why we can really rely on a reading that may help actually tell the patient about how the continuation of the pregnancy or not. Should I advise expectant management? Okay. Here, actually, the patient is in the examined in the emergency room, and she's having really some bleeding, but you want to check whether you send her home and what to tell her. Okay, again, I was looking in the obstetric books. I didn't find how can I advise this patient or what to go by. The emergency room doctors, they have their own publication to say, you tell the patient or you assess the patient if she has soaked more than one pad during her stay in ER, then more likely she needs to be kept, otherwise send her home. And what kind of advice you tell her to send home? Bed rest? No way. Nobody these days tells the patient go and have a complete bed rest, but we do advise her of a pelvic rest. Pelvic rest is different. That means she's not going to jog, which is not going to run, and not to have intercourse or horse ride. So this kind of activities, maybe you'd ask her not to continue with a little bit of reassurance for her. So the reason I'm bringing this here, because this is about time, how should I kind of management I should offer her? I give her these advices, but is there any treatment for that? Well, that is actually published in the NICE guidelines till 2021. The management for these cases is expectant management. And expectant management means, lady, go home and I'll see you in 2 weeks. But that's it. Nothing else I can offer you. So I'm sorry about that. But with the expectant management, I can tell you there are 4 problems can rise for this patient. Number 1 is unplanned admission. Of course, she's driving the car to take her child to school and suddenly she starts to bleed again. You know, I mean, if it is so severe, she go to the hospital. Going to the hospital when she needed to be admitted, this is, nobody will like you for that. I mean, no, the hospital administrations nor the OR list who's been really postponed or deviated. So again, unplanned admission is, likely to occur according to the MIST trial in about 18% of the time. And also we have seen that the bleeding duration, because waiting 2 weeks doing nothing, of course, you're more likely to have more episodes of this heavy bleeding. And if she's bleeding, that means the cervical os is open where the blood is trickling. And here we have a chance for infection to ascend and causing sepsis, which has been reported about 4%. And more interestingly is this prospective, actually multi-center American study looking at more than 16,000 women. And they looked at the amount of bleeding. And they reported that if there was a light bleeding, the odd ratio of miscarrying is 2.5. However, if there was heavy bleeding, the odd ratio is 4.2, almost doubled. And here is definitely, there is a risk for waiting, doing nothing. And I'm sorry to see this kind of, advances not helping the patient, but maybe causing harm for her. Question number 5, then, should I try empirical treatment? Well, we always try empirical treatment when we know nothing, all right? This is something like bed rest or giving SCG or immunotherapy or aspirin and heparin and steroids. Unfortunately, none of those 5 things that I just mentioned can help your patient with threatened miscarriage. No effect at all. So here comes the question, if empirical treatment is of no value, if expected management is really not working, so what should we do? Well, simply medical treatment. Medical treatment with what? With progesterone. Okay, so now we can tell you why progesterone. Because number one, we all know, we studied in our physiology and our obstetric basic science about the development of the corpus luteum, the secretion of progesterone, and then the placenta is taking over to maintain the pregnancy. And that's why they call this hormone progesterone. So it is really significant. It's really of value to consider. But then apart from this hormonal effect, we have what we call the immunological effect. This is actually a very beautiful finding that was really seen over the years, that the lymphocytes at the site of implantation, they have progesterone receptors. They don't have estrogen receptors, all right? And when this progesterone kicked to this, stuck to this receptor, the lymphocytes start to produce a product called PIBF, protein inhibiting blocking factor, which really balance the immunological modulation in favor of the T helper 2 cells, which produce the anti-inflammatory cytokines, and reduce the T helper 1 cells, which produce the pro-inflammatory, and this way pregnancy is maintained. However, if you give a blocking agent to this progesterone receptor interaction, like mifepristone, or if you're giving an anti-BIBF product, then more likely will just tip the TH1 balance, increasing pro-inflammatory cytokines, leading to miscarriage. So immunological arm of the progesterone is something has been looked at carefully, studied carefully. And third factor, I'm telling you why progesterone should be given in a situation like this. There is a bleeding, and if there is any contractility within the uterine wall, more likely more bleeding will take place. And here we have seen from our physiological standards that progesterone reduces the uterine contractions and relaxes the uterus, and that's why they will see no more bleeding or less bleeding. Just to confirm this, there have been some studies done in 2 different parts of the world at 2 different times, but it was really nice to see something replicated, 2004 and 2008. What they did, patients with threatened miscarriage, they asked them to give them a sample of urine, and they measured the PIBF there. And they found the blue line representing those who had low level of PIBF, while the orange line representing those who had higher level of PIBF. And those who had higher level of PIBF, you can see they have continued the pregnancy till term, while those who had low levels of PIVF in the blue, they have really stopped the pregnancy earlier on, even in the first trimester sometimes. So the same on both studies. Now, in regard to the immunological reaction or effect or the PIVA production by the lymphocytes, we can see here that the work of Raghubati, which is really something in the lab, here we have really tested the lymphocytes with different levels of dydrogesterone. He used dydrogesterone. He tried other progesterone. They did not work, but he found that with dydrogesterone, that as he increases the level of dydrogesterone concentrations, there is increased level of PIVF in the dish, and that's how really we can, in a vivo, in vitro experimentation, we confirmed. The same goes with the cytokines variations. So here we can say that, I mean, the question is that, is the macronized vaginal progesterone working in a situation like this? Well, the PRISM trial of Kumarasamy, who did actually a very good job looking at more than 4,000 women in multi-center European centers using atorvastatin, which is a macronized vaginal progesterone, to all these patients. And unfortunately, according to the table you see here, there is no difference between the placebo and the progesterone group. So we can say here, and he himself and his group said, guys, macronized vaginal progesterone does not help patients with threatened miscarriage. While on the other hand, when you look at the dydrogesterone versus macronized vaginal progesterone, I found 5 systematic reviews looking into these threatened miscarriage patients published almost yearly. And what I'm showing you here is that the different studies, and I have all these references on the same screen, tell you that when the patient had used the dydrogesterone, there was a reduction in the odds of miscarriage by 58% according to the Lee study in 2017, while those who received macronized vaginal progesterone did not work. In all these studies, they have confirmed that macronized vaginal progesterone did not work, did not help reduce the miscarriage rate in those cases with threatened miscarriage. However, Wahhabi said dydrogesterone can reduce it by 52%. Wong said that the dydrogesterone reduced the miscarriage rate by 51%. Lai 2020 by 43%. And even Zahao 2021, who actually had a huge number of RCTs in his systematic review, and he mentioned about 57% reduction in the odds of miscarriages by using dydrogesterone versus those who had used the macronized vaginal progesterone, where there was no decrease in the miscarriage rate, and still they're having underwent the miscarriage. Now, according to what I agree, we're gonna just skip the slide and move for the second section of this talk, which is the recurrent miscarriages. Okay, well, as you all know, I mean, recurrent miscarriage, that means you have 2 miscarriages, not 3, not 4 or 5. Once you have 2 consecutive recurrent miscarriages, you label this patient as a high-risk patient of recurrent miscarriage, and then you manage her accordingly. Well, I'll tell you about the management later on, but here I also found 3 systematic reviews, again looking at those patients using the macronized vaginal progesterone versus the dydrogesterone, and in CARP 2015 in his 3 RCTs, where he found there is higher reduction of the miscarriage rate, about 23% in the dydrogesterone users versus 10% in the MVP users. Sacconi in 2017 had 10 RCTs, and again he had showed, I mean, an beneficial effect of dydrogesterone with an RR of 0.72, and then Guillou, which is huge, 13 RCTs included in study just published between 2005 and 2021, more than 2,400 patients. And he concluded that the pregnancy success rate of dydrogesterone treatment was higher than MVP, odd ratio 4.4. That means 5 times. Dydrogesterone better than the macronized vaginal progesterone. He went on actually in his study, if you look at it, beautiful, he compared even the dydrogesterone versus HCG, immunotherapy, combination of HCG and progestins all have shown that the progesterone is superior than the other combinations. So, with regard to this recurrent pregnancy loss, what do we know as a cause of this problem? Maybe history of miscarriage or pre-existing diseases, obesity, it could be endocrine or immunological factors, genetic, or even lifestyle, turn age, etc. However, with all these, factors in mind, believe it or not, the majority of cases of recurrent pregnancy loss are of unknown cause. Almost 75% in one of the publications said remain unexplained. Okay, so I then try to look at the publication where at least I can find one reason from those who the other 25 or 30% that can be really, hovering around to identify specific cause. The ESHRI, European, the ASHRAM, the American, and the Royal College guidelines has identified and agreed that there are three main causes of recurrent pregnancy losses that you should look for, and that's it. Okay, and these are the presence of uterine cavity abnormalities, which is about 17% of the cases, like a septum or other anomalies, antiphospholipid antibody syndrome, which kind of account about 20% of the recurrent pregnancy losses. And here you have to identify it with some kind of doing the antibody, anti-quadruple antibodies, and the lupus, and you have to repeat it 3 months apart, and you should have positive results on both occasions to call a patient as an APS. And then, of course, the thyroid disorders, whether you're doing them hormone level or even antibody levels, which can affect about 15%. So that means here, at least, thank you for these major guidelines to tell us if you're talking about recurrent miscarriage, please look at these three factors. Fair enough. If we know that the majority are out of these three factors, they are unknown, what have we done about it? I thought, let me look at the big guns here. Of course, nothing like the RCG Green Top guidelines, all right? And in their publication 2023 on recurrent miscarriage, Green Top guidelines number 17, they had that part regarding the unexplained. They went the whole guidelines looking at the genetic and the endocrine, whatever. But what I need the majority, which is really the 75% of cases. What shall I do? What did they write about them? Only this part I'm showing here on the screen. Unexplained recurrent miscarriage, 7.8, 7.1, endometrial scratch. They mentioned it to say that it doesn't work, all right? And then psychological support. So here, actually, what they're trying to tell us, the Royal College here, is that the progesterone that can be used only if you have a history of bleeding with a case of a miscarriage. So, first of all, they advise for psychological support. That means, okay, I'm sorry for your loss, but I'm not doing anything. If she's not bleeding, I'm not giving her any medication. Is that believable? Well, it is unbelievable. So this is the RCG. What about the ESHRI? ESHRI, again, they put their guidelines in 2022 regarding recurrent pregnancy losses, number 17, and they had that portion here regarding the unexplained recurrent pregnancy losses. All right, and out of all these, you can read through them. The lymphocyte use, the glucocorticoids or heparin, whatever. But what they have, when you read through them, you can find that out of 9 items discussed, 8 declared by themselves strongly of no value. Only one part within limited value or condition, 2 conditions, 3 or more pregnancy losses, and now she is bleeding. Then you may give her the micronized vaginal progesterone. Well, wait till you find somebody like this. Well, still we have a majority of patients gonna miss their advice. So again, this is something unbelievable. You are not really helping your patient. So the micronized vaginal progesterone reduced the risk of recurrent miscarriages. Well, the same guy, Kumarasamy, in his PROMISE study, he used that micronized vaginal progesterone for those with the previous 2 recurrent miscarriages, and according to his outcome, no significant difference between MVP and placebo. So it doesn't work. What about if you say, does the MVP improve the live birth rate in 13 miscarriages? even with previous miscarriage. According to that finding of the NICE guidelines, the Australian did another report, study, which is published just 2023. It's called the STOP trial. And you can see here, those with previous 2 or 3 miscarriages and have the bleeding, or at this time, would the micronized vaginal progesterone work? And you can see here, there is no difference between the MVP treated and the placebo group, whether they had, in general, or maybe we have 1 a miscarriage or 2 miscarriages previously. So the answer is still is no. Well, what about micronized vaginal progesterone for the sake of recurrent miscarriages in another publication? We're trying to find out if that will help out. I here mentioned to you the FIGO good practice recommendations published by Hisham and his group in 2023. And you can see here that their recommendations, the 8.1 for vaginal progesterone, 8 and 10.1 for injectable progesterone, their statement says vaginal and injectable progesterone supplementation during pregnancy is not recommended, as there is no beneficial impact on the first trimester recurrent miscarriage, with strength of recommendation being strong. So everybody is telling here, I mean, guys, stay away from the micronized vaginal progesterone. It does not help in the recurrent miscarriage, and it does not help with the threatened miscarriage. Now, here I'd like to introduce to you the Saudi guidelines. The Saudi guidelines, which is really published earlier in the 2014, and there we have actually recommended the use of dydrogesterone for threatened and recurrent miscarriages. And since we found the evidence accumulating after that, since 2014, we decided to have another group of expertise and publish another update in 2019. Simply, the Saudi guidelines are telling you the following 5 recommendations. Number 1, regarding micronized progesterone, available evidence insufficient to recommend it for the use or the management of threatened and recurrent miscarriage. Recommendation 2, dydrogesterone, as per evidence, we recommend it for both threatened and recurrent miscarriages. Injectable, available evidence insufficient to recommend it for the use and management of threatened and recurrent miscarriages. And combined, of course, I'm sure you have seen patients coming with a bag having the injectable, the vaginal, the oral, and whatever. Altogether taken it, again, we have found that there is no benefit of using all this combination. And the recommendation number 5 was mainly to say that dydrogesterone is safe and not teratogenic according to the evidence. Now, in addition to these 5 recommendations in the Saudi guidelines, we have also attached 2 position statements just to tell our doctors what to use in terms of the threatened and recurrent miscarriages when they face them. So, for women presenting with clinical diagnosis of threatened miscarriage, bleeding in the first trimester, give 40 milligram loading dose, which is 4 tablets, 10 milligram each tablet, loading dose, and then take 1 tablet, which is 10 milligram, 3 times a day, throughout the bleeding time and for 1 week beyond, okay? So you wait till 1 week, no bleeding, and then maybe you want to reduce it or you cut it off. So this is how we actually recommended it in our guidelines. Another position statement for the recurrent miscarriages. We said exactly, you have to have a history of 2 or more recurrent miscarriages. Rule out the 3 known causes, the anomalies, uterine anomalies, the APS, and the thyroid. You rule them out, they're all negative, then you can call this as an unexplained recurrent miscarriage. Then you can give dydrogesterone in the dose of 10 milligrams twice a day from the minute she got pregnant till 20 weeks of gestation. I said from the minute, that means when the patient is with you in her second loss, you can easily give her the prescription and tell her, once you get pregnant again, you have a positive pregnancy test. You don't need to wait for fetal heart pulsation at everyone seeing a sac. Once that test turned positive, you start taking the dydrogesterone twice a day till 20 weeks of gestation. And since that publication, the Malaysian, Chinese, Taiwanese, and even Thai public guidelines have been printed and introduced. Now, why the dydrogesterone works, why the micronized progesterone doesn't work? Here is an important fact that both molecules are the same, and both are natural, of natural source. If you want to call one of them natural, actually the other one, which is dydrogesterone, is the same, is coming from the same source, which is really a plant, that the plant gets undergo the micronization and lead to the micronized vaginal progesterone, or maybe light exposure and then lead to the dydrogesterone. This molecule is a little bit concave because of the presence of double bond between C6 and 7, and also there is a methyl group in the back of C10, and that led to that concavity of the molecule. This molecule, actually, this shape made it much better to fit in the progesterone receptors. And by doing that, it became as more bioavailable. So the bioavailability of the dydrogesterone is about 28% compared with only 4 or 5% for the micronized vaginal progesterone. And accordingly, once you have higher bioavailability, then you can use low doses. And as you all know, you only give 10, 20, or 30 milligram maximum dydrogesterone. Well, if you want to give MVP, you have to give 400, 600, even sometimes 1,000. Huge doses. The other reason that makes dydrogesterone is unique because of its fitting within the progesterone receptors is that becoming it's unique in effect. So it does not really having any effect on other receptors. So I mean, like glucocorticoids or androgenic receptors, and that's why dydrogesterone is very, very specific compared with other progestins. Moreover, people think that when you give this micronized vaginally, then more likely it will sweep through the uterus, which is very nearby. Well, I mean, let's look with the actual titration of the dose of the levels of progestin in the circulation of those who had the vaginal progesterone. You can see, yes, it increased in the uterine vessels in the first 2 hours, but then dropped quickly. While if you take the oral dydrogesterone, it will get absorbed very quickly. It reaches within 30 minutes to higher levels, to the maximum level within 2 to 1.5 hours, and even lasting for up to 8 hours. So it has a more rapid absorption and maintained for longer time. Here is the benefit of oral versus the vaginal. Of course, oral is more convenient and easy administration, whether it is vaginal or even rectal. You know, then sometimes people talk about rectal, which is really not also appropriate in terms of the absorption and effectiveness. But anyway, it's not really, it's cumbersome, and it's cannot really sometimes cause irritation and requires really private rooms to apply it. And that's why the acceptability by the patients, you can see in the columns here in the dark navy, that the dydrogesterone is more acceptable and attractive to the patients. This is the real, really juice out of all the guidelines that I have come across, put it in clear wording, the Russian recommendation. They said, after full switching from micronized vaginal progesterone to dydrogesterone in threatened miscarriages, plus 18,000 children a year. What does that mean? That means they have saved the life of 18,000 children by giving the dydrogesterone. So if they were not giving dydrogesterone, these 18,000 lives would have been in the bucket with the bleeding. Now, regarding the Saudi guidelines, actually, I'm proud to say that this is a very distinct group from Ireland that they were looking at all the publications regarding the management of recurrent miscarriages published 2021, and they had found 32 clinical practice guidelines, and they put something like more than 300 recommendation criteria in order to specify the integrity and the appropriateness of each guideline. You can see here there are about 11 guidelines or publications, sorry, from US, one from Australia to Canada, and Saudi Arabia. There is one which is my publication. And they have actually indicated that there is still, among all this, there is some kind of more work to be done in order to improve it. And they used the Prisma with color-coded domains to assess different domains of the applicability of the guidelines. And you can see here the publication 2019 from Saudi Arabia. They said they have similar clarity to the ASRAM, the NICE, and the RCOG, but better scope, purpose, and applicability than them. So it shows you really, I mean, it's a great approval from the international societies. So did progesterone is safe? Absolutely, because it's been going in the market for more than 60 years. More than 113 million women have used it, and more than 20 million fetuses been exposed to the progesterone, because we all know that we're giving it in the first trimester during the time of the organogenesis. And it has been, there hasn't been any specific organ teratogenicity that has been reported, because it lacks the estrogenic, androgenic, anabolic, and corticoid properties. And also it has been found to be with great confidence that there is no any side effects to it in terms of fetal development. The REASSURE study that came in 2022 is really trying to also look into those publications that came in between here and there, trying to cause or really point some kind of anomalies like heart or hypospadias or whatever. But anyway, they try to filter these publication. Some of them actually been retracted from their journals, and that's why when they published this and they looked at the about 5 studies that has been proven to be significant ones, and to look into the incidence of the progesterone in terms of causing congenital anomalies, you can see the RR here is 1. It's not below, it's not higher. And that's why they kept on with the second publication after that. This is a group from Spain, Germany, and the US, and they called it the REASSURE Study 2. And here they have included even more studies, more than the other 5, and even classified them according to the strength of the study, whether it's high quality or low quality. But they have reached the same conclusion, that this is the highest current level of evidence, which remove the existing uncertainty caused by poor quality and retracted studies. This is my last slide, ladies and gentlemen. In conclusion, I say that treating miscarriage with concrete evidence. Miscarriage is taken up lightly by doctors, great psychological impact on couples, great financial burden on healthcare, so be smart. Management, there is no place for expectant management with threatened or recurrent miscarriages, so be active. Start the progesterone. It is the only safe progestogen with the strongest evidence to treat such type of miscarriages. And the progesterone effective and safe with the REASSURE 1 and 2 studies published 22 and 24. Recent guidelines and systematic reviews in the last 5 years also have proved it. And here I'd like to thank you from the bottom of my heart with all these languages. Thank you.
Well, thank you very much indeed, Dr. Hisham Arab, for this beautiful presentation. We've had many hundred people logged on this afternoon, and the applause has been deafening. We have a few questions and we have a few minutes left. So would you mind if I set a few questions that you might like to address? Would that be okay, Dr. Arab?
Yeah, sure. Shoot, please.
Okay. The first one is that some people are slightly intrigued by Professor Leslie Reagan's endometrial scratch. You did have a slide there with Leslie Reagan had the guidelines of the Royal College, and they looked at whether or not an endometrial scratch was effective in miscarriages. Could you explain what is an endometrial scratch?
Well, unfortunately, this has been like tried with certain cases of recurrent implantation failure. So what they do after the egg collection and just before the ET, they do actually hysteroscopy, and they scratch. I mean, literally, they scratch the endometrium, and then they do the embryo transfer, hoping that will prevent the loss. But definitely, we have seen that this didn't work.
Okay, so it's of no consequence of historical interest only and of no clinical significance. We've seen, and you have shown us all the evidence, including guidelines, including those from your country, that dihydrogesterone is superior to micronose vaginal progesterone in first trimester loss. The question that comes over here, you've also mentioned over there that it can be used up to 20 weeks. Is that correct?
Exactly. For recurrent pregnancy losses, yes, we can use it up to 20 weeks.
Thank you. If a woman in the second trimester has bleeding, she didn't have it in the first trimester, but she has it in the second trimester, is there any evidence that you've come across to suggest that the dihydrogesterone should also be used under these circumstances of second trimester miscarriages that are threatened?
Yes, if you're talking about second trimester between 14 weeks and 20 weeks,
yeah,
yes, the evidence is there. We have different publications looking at that period of time. The only problem is if talking about between 20 and 28 weeks, for example, or 26 weeks, and then we don't have the literature to support it. But if you ask me, I'll do the same.
Okay, so there's no reason necessarily to stop. What we do over here in this country, in the fetal assessment clinics, typically around about 12 weeks, the ultrasonographer measures the cervical length. If you have cervical shortening, less than 25 millimeters, is there any value in administration of dihydrogesterone under these circumstances?
This hasn't been really looked at, I mean, in terms of preventing the dilatation. The thing is, all the studies that have been reported using the micronized vaginal progesterone, and even that one lately has been really found to be an ineffective. Honestly, the only patient really I do actually start the treatment is the symptomatic one if she is not a recurrent miscarriage and should have a pain or bleeding. But just for the sake of short cervix, no, it's not an indication.
All right. Now, if you had to start it for a person that wished to begin it, what dose would you use, Dr. Arab?
In terms of what condition?
Shortening of the cervix. If a person felt the need, there's a question over here. If they had a patient that had a cervix at the beginning of the second trimester, 12 weeks, that was found to have a cervix that was shortening, what dose of dihydrogesterone would you suggest?
Okay, if she's asymptomatic and just a mere finding of having a short cervix,
yes,
and I want to use dihydrogesterone, I'll give her 2 tablets a day, 10 milligrams twice a day.
10 BD.
Yes.
Okay. Another question. Have you come across any evidence regarding the use of dihydrogesterone in the third trimester? I know this is not the topic, but people have asked this question, and it's a common question. Is it of any use whatsoever as a tocolytic in the third trimester for women that have premature labor?
No, dihydrogesterone is not a tocolytic agent, but can be used as an adjuvant to tocolysis. There are some publications out there to show that when dihydrogesterone was used as an adjuvant to the tocolytic agent, they have increased the gestation age by at least 1 week.
Wow. And in that case, what dose would you use? The same as what you mentioned before, 10 BD?
Exactly.
Okay. Thank you very much. Is the use, final question, but we've been asked by Abbott if they wouldn't mind us showing their video at the end because it didn't work so well at the beginning. The final question, just to give Abbott sufficient bandwidth before 6 o'clock and 7 o'clock in your case. The final question is the route of administration only oral, or are the other forms of administration also acceptable? Is it only oral or others?
Yes, the current use of dydrogesterone is only oral. I have heard doctors trying to smash the tablets to put it vaginally, but I don't see any reason for that. Even if the patient is having hyperemesis gravidarum, for example, I tell her take with a small sip of water between meals or during the meal. If you vomited it, take another one. But still, I mean, this is the more appropriate route because this is where most of the pharmacokinetics actually studies, they looked at its absorption through the gut.
Okay. Now, the one very last question, we keep having very last questions. If a
Okay.
woman, this is just what you've said now, if a woman has severe hyperemesis and she can't keep a thing down, she's been hospitalized, can it in any way be used rectally if she has a threatened miscarriage?
As I said, people have tried these things, but really we don't have any studies looking at showing the level of absorption there and its significance. But as I said, I mean, try with your patient to give her some reassurance, make sure she can swallow that tablet at any one point of time during her day.
Okay. Well, thank you very much indeed, Dr. Hisham Arab. It's been wonderful listening to you. We've had many hundreds of people logged on this afternoon throughout the continent of Africa. You've presented a beautiful presentation, and we look forward to having you maybe one day, maybe this year, again on our platform. Just to remind everybody that we have FIGO 2025 in Cape Town in October. And if you want to get your pals together and come through, there's a special discount for group attendances at FIGO. So we look forward to having as many people as possible. And of course, we hope Abbott and Hisham Arab are able to come and be with us at that time in October. Would you be coming through to FIGO?
I have a thought about it. I might arrange for it. Yet I haven't really decided finally, but yes, I'd love to.
I'm wondering if Abbott's listening to this. Right, Dr. Hisham Arab, it's been wonderful having you over here. And in the last 2 minutes, I promised Abbott that we would be able to show their video. A great big thank you to the Abbott's people. They're all there. Great big thank you, of course, to Nadir. And we see you all over here on the same platform next week at the same time, the same place, safer. So, Nadir, if you could roll the video, please.
Thank you, Peter.
Progesterone is a steroid comprising of 3 cyclohexane rings and 1 cyclopentane ring. It is manufactured for therapeutic use from the wild yam root Dioscorea species. Due to rapid first-pass liver metabolism, progesterone has variable concentrations and very low oral bioavailability. Therefore, it is administered via injection or vaginal route, which are not easy to use and associated with side effects. Dydrogesterone was introduced for clinical use under the trade name Dufeston in the 1960s. The treatment of conditions associated with progesterone deficiency. The manufacturing process of dydrogesterone is highly complex. It starts with the chemical modification of progesterone, followed by a critical phase of transformation into dydrogesterone. This is done by passing it through UV light at an appropriate wavelength, intensity, and time sequence, resulting in a unique, modified retrosteroid structure. This manufacturing process makes dydrogesterone the only commercially available retroprogesterone. The bent conformation of oral dydrogesterone enhances the rigidity of the molecule compared to progesterone. Due to its unique structure, dydrogesterone is highly selective for progesterone receptors, supplementing deficiency of endogenous progesterone. It has negligible interaction with other steroid receptors, resulting in a lack of androgenic, estrogenic, glucocorticoid, and mineralocorticoid effects that can occur with other progestogens. Dufeston, containing 10 milligram dydrogesterone in each tablet, is formulated to have good bioavailability, enabling convenient, patient-friendly oral administration. Improved oral bioavailability and the receptor agonist activity of its metabolites causes secretory transformation of the endometrium, progestational activity, at a dose 10 to 20 times lower than micronized progesterone. Various progestogens have been investigated to support endogenous progesterone in the treatment of luteal phase deficiency. Only Dufaston, progesterone, and 17-alpha hydroxyprogesterone caproate are currently approved for clinical use during pregnancy. In women undergoing assisted reproduction, Dufaston supplements endogenous progesterone and provides orally effective luteal phase support, contributing to successful and comparable pregnancy outcomes versus vaginal micronized progesterone. To date, around 113 million women throughout the world have experience with Dufaston, including 20 million fetuses exposed to dydrogesterone in utero. Progesterone is a steroid comprising of 3 cyclohexane rings and 1 cyclopentane ring. It is manufactured for therapeutic use from the wild yam root Dioscorea species. Due to rapid first-pass liver metabolism, progesterone has variable concentrations and very low oral bioavailability. Therefore, it is administered via injection or vaginal route, which are not easy to use and associated with side effects. Dydrogesterone was introduced for clinical use under the trade name Dufaston in the 1960s for treatment of conditions associated with progesterone deficiency. The manufacturing process of dydrogesterone is highly complex. It starts with the chemical modification of progesterone, followed by a critical phase of transformation into dydrogesterone. This is done by passing it through UV light at an appropriate wavelength, intensity and time sequence, resulting in a unique, modified retrosteroid structure. This manufacturing process makes dydrogesterone the only commercially available retroprogesterone. The bent conformation of oral dydrogesterone enhances the rigidity of the molecule compared to progesterone. Due to its unique structure, dydrogesterone is highly selective for progesterone receptors, supplementing deficiency of endogenous progesterone. It has negligible interaction with other steroid receptors, resulting in a lack of androgenic, estrogenic, glucocorticoid and mineralocorticoid effects that can occur with other progestogens. Dufaston, containing 10 mg dydrogesterone in each tablet, is formulated to have good bioavailability, enabling convenient, patient-friendly oral administration. Improved oral bioavailability and the receptor agonist activity of its metabolites causes secretory transformation of the endometrium, progestational activity, at a dose 10 to 20 times lower than micronized progesterone. Various progestogens have been investigated to support endogenous progesterone in the treatment of luteal phase deficiency. Only Dufaston, progesterone, and 17-alpha hydroxyprogesterone caproate are currently approved for clinical use during pregnancy. In women undergoing assisted reproduction, Dufaston supplements endogenous progesterone and provides orally effective luteal phase support, contributing to successful and comparable pregnancy outcomes versus vaginal micronized progesterone. To date, around 113 million women throughout the world have experience with Dufaston, including 20 million fetuses exposed to dydrogesterone in utero.